to the Zeiss Ophthalmic Medical Education Summit hosted by Zeiss and Eyes on Eye Care. My name is Joe Panarelli. I'm a glaucoma specialist at NYU Langone Health, and I'm going to be moderating a session today with Doctors Jessica Steen and Anu Lau. And we're going to be walking through a few complex cases that take us through both the medical and surgical management of glaucoma, as well as some key diagnostic questions that many of us face when treating glaucoma patients. So thank you again for participating. I'm going to turn it over to each of the doctors to introduce themselves.
Hi, I'm Jessica Steen, an optometrist and director of the glaucoma service at Nova Southeastern University College of Optometry in Fort Lauderdale, Florida.
My name is Anu Lau. I'm an associate clinical professor at the State University of New York and the instructor of record of the glaucoma micro-credential program here at SUNY.
All right, so the case that I'd like to bring forward for discussion, because I truly think there is a lot to unpack here, is that of a patient who's currently 60 years of age, and she was diagnosed with primary open-angle glaucoma in 1998. She was 36 years of age at the time of diagnosis. She was initially treated with timolol 0.5% in each eye, and she initially presented to our clinic about 10 years after the time of diagnosis on timolol, with pressures in this 18 to 20 millimeter mercury range. And at this point, we were not aware of her peak untreated intraocular pressures. She has thin corneas, central corneal thickness less than 500 microns in each eye. Visual acuity is 20/20. There is no afferent pupillary defect, and color vision's unremarkable. Now, systemically, she has medically treated hypothyroidism, and she is certainly not hypertensive. Now, if her max blood pressure measurement in our office, if you can call it a maximum reading, was 111/78 millimeters mercury. She has no family history of glaucoma, but potentially of note here, her mother has Alzheimer's disease. Now, for us that really embrace and actually utilize technology, I am still an advocate of traditional standard fundus photography. This is a technology that allows us to identify change objectively over time and manage patients really objectively over 10, 20, 30, 40 years. A technology here that certainly doesn't change. When we look at our optic nerves in 2010, we see inferior neuroretinal rim defect in each eye with a very subtle nerve fiber layer change. Superior temporal, there is also a subtle nerve fiber layer defect. We see early nasal step in each eye that's consistent with her optic disc appearance. And as we go through this case, we are going to see different types, different strategies, different patterns of visual fields. This just happens to be a 30-2 CETA fast that was performed in the right and left eye. Now, remember these days, early in nerve fiber layer imaging, we have objective, quantifiable data about the nerve fiber layer defect that this patient has. We see symmetric nerve fiber layer defect in the right and left eye, inferior, certainly greater than superior. And certainly interesting here, this was a time before the commercial widespread availability of ganglion cell complex analysis. So at this point, when we're talking about OCT analysis, it was all about the retinal nerve fiber layer. Now, if we move forward through this patient's disease course, we see clear functional change over time. We've lapsed about 8 years here, and now this is a 24-2 CETA standard that was performed. We see deepening of the visual field loss that now extends beyond that vertical midline. And if we really look at the paracentral defect in a little bit more detail on a 10-2 visual field, a 10-2 CETA standard, certainly we start to think about the functional considerations in this patient's case. When we watch patients for long enough, we know that disease progresses. But when we think about this patient's early age of diagnosis, relatively young age, and intraocular pressure readings at where progression has been identified in this 14 to 16 millimeter range, we really start to think about what else can or really should be done. So when we're looking at progression, we're really focusing on the visual field in this particular case. Mean deviation and that change in the mean deviation slope over time doesn't look as impressive as when we look at the visual field index. Now, I like the visual field index progression analysis for this patient because it does weigh those paracentral points more heavily, understanding that there is more functional implication in loss of the paracentral visual field versus those non-central points. So this particular case, she is truly an ideal patient to manage and to work with. She is diligent, she's aware of her disease process, and really understands her central role in chronic disease management when we're talking about medication and medical therapy. So she is as perfect as someone can be with adherence to medication. Her only lapse in medical therapy occurred when she unexpectedly left the country for longer than planned. So there was self-discontinuation of medication because she ran out of medication. By the time she came back to our clinic, she was off all medications for about a 4 to 6 week period, which really did allow us to better understand her peak untreated intraocular pressure, which was only 19 and 21 millimeters mercury, versus this 14 to 16 millimeter mercury range on latanoprost, dorzolamide timolol, and brimonidine. So, Joe, any thoughts on this case at this point? We have progressive disease at a relatively low intraocular pressure.
So many great pearls to unpack here. Really just a brilliant case, and one I feel like we all come across day in and day out. And honestly, it's the type of case that we lose a lot of sleep over for so many reasons. Are we doing too little, or are we doing too much for this patient? What is the right answer? And I'll start off commenting on a few things. The history, so important. Knowing what those untreated IOPs were, knowing about the family history, understanding the genetics in the family. Did anybody go blind? Did, first degree relatives, cousins, who else has the disease? Because remember, pressure is one of many risk factors for this disease. It is the only modifiable risk factor, but there are other factors at play. And I think we always have to take that into consideration, because patients, unfortunately, and I think families and even other doctors will feel that, well, if I control that pressure, the disease is going to be stopped, right? And that's not always the case. And I think that's what you have to sometimes understand, is that you could do diurnal curves on these patients with, eye care homes and see that the pressure is really, there is no volatility, but that patient may still get worse over time. And the question becomes, how do we change the curve that you're presenting here in terms of that visual field trend, that downward trajectory? And oh boy, I'm not going to pretend I have an answer to that. But one thing I do think is important, I want to ask both of you, look at the visual fields and the variability. I think one point that's important here is how much you have to repeat visual fields to confirm or refute progression. So how many visual fields are you doing a year on a patient like this? And what kinds are you doing? Because you did allude to it. There is some value to different kinds, and whether you're doing C to standards or C to fast or faster or the dash Cs. I mean, walk me through what you would do for this patient for your testing each year.
So in this particular patient, I've shifted to 24-2 C to faster at least once a year, and a 10-2 at least once a year. Now, we've really focused on functional measurements rather than running OCTs frequently on this patient, just because of her really long-term robust visual field data. It's really been the best way, in our opinion, to monitor this patient over time. But my typical for most of our either new presenting cases in our clinic, or I am transitioning patients from a 24-2 to the 24-2 C to faster.
Anu, what do you feel about the reliability of the 24-2 C faster? Do you have any questions about that?
Yeah, no, that's an excellent question. So, historically, the way that I learned it was always the C to standard. That's exactly what we did, and that's how I was trained. However, there is data that sort of shows that, the C to fast, for example, if you have long-term data over time, and I think it was Dr. Crabb that showed this data, that the variabilities that you get from the C to fast or faster algorithms tend to even out. So, if you can only do one visual field, then sure, the CETA standard, because of that double threshold bracketing, you get more accurate results. But if you're doing many visual fields over time, the benefit of that CETA standard really decreases. And I think you can get some really good data with the CETA fast and CETA faster algorithms.
Well, Jessica, I agree 100%. I think this is a perfect case for a 24-2C for a variety of reasons. I think the key thing you have to remember is, you have to have a happy patient, because a lot of times the patients, the more testing you ask of them, the less pleased they are to do some of the testing. They skip it, they don't do it. So I think you have to be cognizant of all that. Yeah, it may sound good that, oh, I'd like to have 6 visual fields over 2 years because that's what they found in the collaborative normal tension glaucoma study. That's not practical. That's not what we're doing here. We need to find ways to keep our clinics running and to not miss things. And so I think that's just important. And I'm curious about now the structural testing, because what's interesting here, when you looked at these fields, we're mostly limited to the superior hemifield. And I might make the argument that I don't know what I can do to stop what's going on up there. My bigger concern is making sure that those inferior hemifields don't become involved. And I think that's where you have to be careful sometimes. My students sometimes will get too many 10-2s, and I'm like, hey, wait, zoom back. Don't forget, we want to make sure there's no beginnings of changes in those inferior hemifields, and maybe watching very carefully structural changes on the OCT. So I'm curious, how often are you getting an OCT in this patient?
So OCT has been a lesser priority, I'm not ashamed to admit, which has been about every 1.5 years on this particular case.
Yeah, and the main reason I'd ask is just tracking to see it. And again, maybe using some of the software analysis to see if there are some changes in the superior nerve fiber layer, to see if you can pick up things now on the ganglion cell analysis that maybe we couldn't see before. But I will also go back to a point you made. Man, the photographs, it's amazing what you can see. And the first thing I picked up were those nerve fiber layer defects that you pointed out so nicely. And that's really just hard to sometimes pick up clinically, no matter how perceptive you are, no matter what filter you put on there. Nothing really shows you quite like the disc photograph. Now, what's interesting here is how we're classifying this glaucoma. Is this POAG? Is this NTG? Is it a mix? And I think classically, when we talk about low tension glaucoma, there's one side of the camp that says, all right, low tension glaucoma, I'm thinking patients who have, vascular abnormalities, problems with autoregulation, Raynaud's, cold hands, cold feet, poor circulation, hypotensive at night. And then there are others who think that it's just all spectrum of one disease where there is probably some IOP volatility. I actually think there's like 2 separate forms of NTG. There is that former condition I was just talking about, and then there really is the latter, where I think there's a large genetic role to what's going on here. This patient has just something about their lamina cabrosa, something about maybe their CSF pressure that we don't totally understand, something about the gradient at the optic nerve head. I think we'd all agree. The only way to really fight this, though, I think, is to get the pressure lower. So I'm curious from you two, where do you go with topical therapy? What do you think about laser? Is it something we should pursue, or are you kicking this over to me here to think about doing a trabeculectomy? What are your thoughts? How far do you take this, and for how long?
At this point with this particular patient, progressive disease in the mid-teens, we did consult with a local glaucoma surgeon, someone that you know very well from your time in South Florida, who had advocated for trabeculectomy. Now, in this patient's case, at that point, she was underinsured and was concerned about the financial obligation, so had begged to try to defer surgical intervention with any other medications possible. So we worked with her. We talked about additional medical therapy, and we made the decision together to add notarsidil. So a fixed combination of notarsidil and latanoprost. We kept on dorzolamide timolol and brimonidine. And this has been about 3 years on this particular combination of topical therapy alone. And her intraocular pressure has stabilized at this 8 to 11 millimeter mercury type of range, which was surprisingly remarkable for this one medication change.
And that's kind of the claim to fame, I think, for these new Rho kinase inhibitors, is that, they really work well wherever you add them in your treatment algorithm. At least from some of the data we've seen from some of their phase 4 studies. And I've seen it. There's not many medicines that can get you to drop below your floor or that episcleral venous pressure. And this is one of them. And this is what I would hope to achieve with a trabeculectomy, is consistent pressure reduction in this sort of 8 to 12 range, which is not easy to do with our traditional glaucoma medications. And honestly, not something I'd expect to see with laser therapy either. So kudos. I think this is a great job.
So at this point, she's remained stable. To bring in our last type of visual field at 24-2C, see to faster. And as you said, paying very careful attention to the inferior visual field here at this point is unaffected or minimally affected. But we have a young individual who's shown progressive disease with paracentral functional damage here. So this is someone that, as we're watching her over these next, hopefully 30, 40 years, we certainly have a lot to think about in maintaining her pressure and maintaining her functional status here.
That's the key, I think, is looking at the patient's age. If this patient's 75 years old, I'm not nearly as worried. But you're talking about a patient who's only 60 years old, and with the way life expectancy has increased over the last decade or so, you have to be thinking, I need to keep this person doing well for a longer period of time. And I think that's what we sometimes forget, is our job is to preserve a patient's functional vision in their lifetime. And so, listen, they were doing okay. That rate of change wasn't that bad. I agree that we had to get a bit more aggressive because there was some change, but that's always the key. And that's where good conversation with the patient is so key, to ask them how they feel their vision is changing over time. Because believe it or not, the patients will know what's going on. They will always be able to, it's amazing. They can go within a few percentage points of that VFI of how much vision they've lost. I'm always very impressed with what a patient knows, even when it's something like, that visual field on the right. And, Jessica, I think we talked offline a little bit about thoughts on relatives of this patient and how aggressive to be if you are seeing this patient's daughter or this patient's son. I'm curious to my panel in the last few minutes we have here, how aggressive would you be with a child of this patient, who maybe has a borderline pressure?
So in this patient's case, her daughter's 38 years of age. She has been seen every 3 to 4 years in our clinic with nerve fiber layer imaging, ganglion cell complex imaging, with an intraocular pressure in this 20 to 22 millimeter mercury range, untreated. Just recently, when comparison of her nerve fiber layer and ganglion cell complex showed change, so statistical significant, but really clinically significant, more than about 12 micron change in looking at the clock hour analysis, we made the decision to treat. She has thin corneas as well, but understanding her mom's disease course and trajectory, at this point, we are being relatively aggressive, and there is no visual field loss in the daughter, but trying to delay or prevent any functional change in this case, we have been aggressive.
I would 100% agree, and I would do the same. I think it's always the question. I think a lot of us sometimes are duped, even for patients with a normal pachymetry, into thinking that they have to have more significant pressure elevation. But if you look at the Baltimore Eye Study, the Barbados Eye Study, and so many others, so many patients come to your clinic with a pressure between 20 and 24 at diagnosis. And when you see results of classic trials like OATS now being carried out through 20 years, we see, there is a real risk of conversion. And I think, you got to be very careful, and you have to sort of weigh each of these risk factors a certain way in your head. And nothing beats your gut judgment when you're taking care of, one of these family members, and you just sort of get a certain feel and you're like, now is the time. So I think that was a great case. Thank you so much. And I think we'll move on to case 2 and hopefully have another lively discussion here.
All right, so this is a case that I'm sure many of us kind of deal with. This is a case where I have a patient who essentially presented from an outside clinic. And I know that we all acquire patients from all over, and we don't have the benefit of having years worth of data like just this case. So this is the patient that I acquired with a history of chronic angle closure glaucoma, previously managed in an outside eye center, and presented to us with a history of an LPI back in 2018. Previous history of treatment with latanoprost and brimonidine, and he was most recently taking rocklatan twice a day in both eyes in another medication. However, he's been off medication for 2 months. He recalls that his pressures actually have been in the low 20s despite being on eye drops. So our thought is his eye pressures are probably in about the 20s Tmax without any medication. He feels that the eye pressure lowering medications are ineffective in terms of lowering his eye pressures, which kind of led to variability in how he's taking the medications. He has an unknown family history, is adopted, and we weren't able to get a lot of his previous data from the outside providers. He was seen at our eye clinic back in 2020, and I acquired him in 2021. So the data that I have is from early 2021. So when I saw him in my glaucoma service, you can see that he has good vision without any corrections. He's not a myope or a very high hyperope. His eye pressures in office were about 20 and 22. And again, he's been without medication for 2 months. So this is essentially what I assume that his Tmax is. He underwent LPI temporally in both eyes. And as you can imagine, in someone who has a history of chronic angle closure glaucoma, it's quite appropriate to do an LPI. If you recall from the ZAP study, those patients were primary angle closure suspects. They did not have glaucoma. If your patient essentially has glaucoma or evidence of PAS, I think it's absolutely appropriate to get this patient in to get an LPI as soon as possible. Looking at his gonioscopy, and I think it's always important when you're classifying disease to look at the gonioscopy readings. And as you can see, that this patient does have some PAS superior nasally in both eyes. I'm going to show you some anterior segment OCTs here in a moment as well. Of course, you want to look at the back portion of the eye. So let's have a look at his optic disc photos. Don't know how well they show up on the Zoom here. However, as you can see, this patient does have significant cupping in both eyes. He actually has large size optic discs in general. Again, probably doesn't show up that well on the Zoom screen, but you can kind of see that he does have some nerve fiber layer reflection here, but really no nerve fiber layer reflection on that inferior areas in both eyes and superior in that left eye. The other thing that I look at with photographs, and Jess mentioned this in her case as well, is that it is very important because I feel that you want to rule out any other type of optic neuropathy. So I'm looking for things like pallor on the optic disc. We know from the OATS study, we tend to miss things like disc hemorrhages. So taking photographs to look at disc hemorrhages are so important. This patient does have some peripapular atrophy, no signs of pallor in the discs. I also don't see any signs of vascular type changes that would indicate a previous vascular event like a BRVO, CRVO, or anything like an AION causing visual field defects. I'm going to show you those visual fields here shortly. When we look at this patient's angles, now remind you, these are post LPI. These are essentially taken here. This is the right eye here on this side, and then the left eye here on this side. You can kind of see here that nasally in both eyes, it's a little bit thin, or narrow, excuse me. Just to give you an idea on where structures would be, if you look at the transition zone between that clear cornea and that limbal zone here, this is kind of that transition zone. The scleral spur is usually about 1 millimeter or 2 behind that. So that's likely where the scleral spur is. So this is where your trabecular meshwork is. And you can imagine that, there can be areas of contact. This was taken kind of at that 180 mark. And as I mentioned, that the PAS was actually kind of at that nasal superior end. So in some cases, you can actually get some really, really good images with the anterior seg OCT. I'm just wondering on the panel, how do you guys use the anterior seg OCT, or do you mostly focus on gonioscopy? I will admit that gonioscopy for me is king, and that's what I use for most diagnoses.
I'll let Jess first. What are your thoughts?
I rely on gonioscopy. Where I do find OCT of the anterior segment to be helpful are those cases where you really do want to document and determine true appositional closure and appositional touch. If we're doing OCT in a completely dark room, we're going to get into that mid-dilated state as best as possible versus any light going into the eye with gonioscopy. So you may kind of lean more towards appositional closure with OCT, but in general, it's something that I rarely use and do just rely on gonioscopy.
I agree. I think gonioscopy is still my go-to. It is amazing how many narrow angle evals though I get. I had a lot today, and how many times I put the gonio lens on the patient's eye and they were like, oh yeah, no one did this before. I was like, well, how did you get that diagnosis? How did you get here? And in truth, many of them probably by Von Herrick were kind of narrow, but it is, I think it depends on when you trained. So I think OCT has gotten so much better at imaging the angle that I think I don't use it enough. I use it more for teaching. It helps the patients understand what we're going to do and why a laser might need to be done rather than me just explaining. I think when I explain with images, they leave so much more comfortable with what's going on. And I'll admit, I think I've learned a lot because I was a little biased when OCT first started, being used for the anterior segment when I was finishing my training. It was in its infancy and the images weren't great and we really couldn't image the canal well. We still are limited. We can't really see the posterior aspect of the iris as well as we like, or the position of the ciliary body, but we definitely can see the angle, in much better visualization now. So I'll say I use it, Anu, probably not as much as I should use it though.
Yeah, and I think both of you bring up some really good points. You'll kind of miss things like how much pigment is in the angle, if it's splotchy pigment, if there's areas of PAS on the OCT. But I think other benefits are that yes, you can do it in a completely dark room. No matter how gentle you are with your gonio lens, you are putting a little bit of pressure on. That could make the angle a little bit larger than it truly is in those types of dark conditions. And I think now, with the OCT getting better and better, you can also look at maybe the contour of the iris, things like lens rise, which is pretty fantastic.
I was going to say lens vault is very nice to see, and some of these other parameters. I think one thing I knew that's interesting, and just maybe moving away from imaging for a second, but just even in terms of looking at this angle, what is interesting, patients get called chronic angle closure, which is the appropriate term when they have evidence of disc damage and PAS. But I always got to wonder with nerves like you showed, does this patient have an open angle component to what's going on here? Part of it is just the nomenclature, but it is an interesting question because some of this, makes you think differently when you look at it. A lot of times when I think of true chronic angle closure, I'm seeing patchy PAS everywhere. Sometimes people develop a little PAS just if it was a challenging iridotomy and there was some inflammation afterwards. So I just throw that out there because I think it's interesting sometimes how we use the definition and the way we are managing these patients.
Yeah, and actually, I'm going to summarize this at the end because I actually agree with you in this case. This person has a very small area of PAS, so we're looking at a less than a quadrant. I would say in a quadrant you might see some areas of PAS, but elsewhere it actually looked pretty open. And if you look at this temporal angle, I mean, it definitely looks pretty open. And I don't see any evidence of that splotchy type of pigment that would lead me to believe that this patient has, some history of PAS. So I 100% agree with you. And I'll kind of move on here a little bit.
Every time you see an iridotomy in a patient, I feel like my trainees always immediately, they're a CACG suspect. They have CACG. Right. And I'm like, wait, let's look a little more critically at the angle, post iridotomy. How open is it? Perhaps this patient, just had a very, had this pupillary block configuration. Once relieved, the angle is sufficiently open. So just very interesting. And I think that's where gonioscopy really is so wonderful. But I will say these images are getting better and better. You can really see a lot. And I will say education for patients, I think team is so key. I think patients really do understand it better when they can visualize what you're talking about. Because it took me years to understand the angle. I still don't know if I fully understand the angle, but these images help.
Absolutely. Just to give you guys an idea on pachymetry, this patient's minimum pachymetries are 441 in the right eye and 445 in the left. So again, this is a huge risk factor for this particular patient. Now I'm going to move on to this patient's, OCT. So this is the first OCT and visual field that we took on this patient. This is the example of the combined report, if you haven't seen that there. The right eye is on this side over here, and then the left eye is on the other side, just like so. To zoom in a little bit, let me just sort of talk about that right eye here for a moment. First OCT that I took on him, as you saw from the photographs, this OCT does match up pretty readily with the photographs. As you can see that there's definitely significant loss inferiorly. And we saw that on the photographs where it was very thin in those places and and no longer is seeing anything like Parnathal reflections. And I said, this looks as you would expect it to do. The left eye is actually very similar, where you can definitely see that inferior loss as such. I do want to point out that on my OCTs, I kind of converted to an Enston curve because we know that when it comes to glaucomatous loss, it tends to happen temporally. And in this case, it's very clear to see that inferior temporally in both eyes, that there is significant loss there. That does correspond to what we see on the visual fields. So you can see that this right eye here, superiorly, there's some significant loss there. Although you could argue that this might be a little bit of a cloverleaf pattern. There's quite a few false negatives, but I do believe that this patient does have significant loss in those areas. The left eye, of course, is a little bit worse, to the point where we can't even get a pattern deviation on him, but it kind of makes sense to what we see in the optic nerve. I'm going to quickly move on here to the 10-2s, and that's the discussion that we just had as well. As you can see, the patient definitely has 10-2 nasal loss in the right eye and more so in that left eye there. That corresponds to that inferior temporal thinning and corresponding ganglion cell. So let's sort of talk a little bit about staging, and this is an advanced stage of glaucoma because we are seeing loss within the central 5 degrees of fixation based on AGS definitions. So what do we do for this patient? So for this particular patient, I did start this patient on Travatan. I want to see what I can do, which is a prostaglandin, and thinking to myself that I do want to consider adding additional medications to him in the future. Now, I've seen him a few times since, and I want to show you what his IOP graphs tend to be. So these are the first couple of times that we saw him in our primary eye care clinic, and these are the times that I saw him here. Once I started him on Travatan, I was able to bring his pressures down to the mid to lower teens. However, they do kind of bounce back up a little bit. And when I talk to this patient, unfortunately for him, compliance tends to be a problem. As you recall, he kind of felt that the drops really don't help him much. So just to kind of summarize this case that hopefully lead us to some discussion is that we have a young patient. He's 59 years old. He's African-American with severe glaucoma in both eyes, with unknown family history, thin pachymetries in both eyes, and variable drop compliance. So the idea of potentially adding a drop in this case, would this be helpful to him? And I think, let's sort of discuss our options.
Oh man, again, great case. I'm going to try to, I'm a mentee of Steve Getty, and so I always try to use evidence as much as possible to support my decision-making process, especially when I'm going to need to be more aggressive than I would typically like to be. So you have younger patient, severe disease, poor compliance. I think this patient needs trabeculectomies in both eyes. I think he needs them soon. Why? Look at data from the collaborative initial glaucoma treatment study, the new trial called the CACG trial out of the UK, supporting patients who are presenting with severe disease probably do better with earlier surgical intervention. CIGITs looked at patients with a mean deviation of -10 or worse. They did better going right to trab. I think this patient's compliance is an issue. I think this patient's already lost substantial vision. Now, why trab versus tube? Well, starting IOP is not terribly high. And if you look at some of the results of the PTVT, it does point to trabeculectomy probably being a better primary surgery. That's my just very quick summation. I think we have good evidence to support why this patient probably needs trabeculectomy. Now, that being said, there's always the flip side that there's a surgery, it comes at risk, and this patient who already is having some questionable issues with compliance, is this patient going to comply with all the follow-up that's needed to do a trabeculectomy in both eyes? That's where building a good relationship with the patient is key, and sometimes you don't have a lot of time to do it, but you got to do it.
How about things like, would there be any benefit to do lensectomies, so do a clear lens exchange, potentially angle-based procedures, or is this patient too far gone?
So another great question. I think angle surgery for me, limited utility when you see somebody with that kind of visual field loss. I think the entire outflow pathway is probably diseased. As we talked about before, when you look at things like the EAGLE study, remember, people try to take data from big studies and I think extrapolate the data and make it apply to the patient sitting right in front of them. It doesn't really apply in this situation. The patient's already had iridotomies. I think there's an open angle component to what's going on here. The thin pachymetry, the appearance of those nerves, how open that angle was on gonioscopy. I'm treating this more like an open angle glaucoma patient who does have some focal PAS. I think there's probably some benefit to lens extraction, but not tremendous utility. I think this person needs a low pressure, low steady intraocular pressure. So that would be my feelings on it. I don't know, Jess, any other thoughts from you?
I think one important thing that you brought up, Anu, is staging of glaucoma, which is something that is often lost in a clinical environment. So thinking about the visual fields once again and applying that data to correctly and appropriately staging glaucoma based on AGS and therefore ICD-10 criteria.
And I will bring up one last thing. This is a true severe disease. And by that, I mean, this isn't somebody who has a small point within 5 degrees, who's got an otherwise pretty healthy disc with a deep inferior notch. This person has pretty significant retinal nerve fiber layer thinning with visual field loss in multiple hemifields. This person has true severe disease. And that is something that I do think we can have a whole discussion around, is what really is severe disease. But this person truly does. And I think this person needs some pretty aggressive management. Thanks to everybody who participated and who have been with us this evening. I'm joined by Justin and Anu, and we're going to move to the question and answer portion here. So I encourage anybody who has any questions from either of the two cases to send them our way, and we'll try to get through as many questions as we can. But I think in the meantime, I prepared a few of my own questions for my colleagues here, because I think this is it's kind of fun. We're going to take some of what we've hopefully learned and try to apply it to two clinical scenarios here. And these really are questions not just from a panel, but actually for everybody out there. So we're gonna push this out there in our poll. So we're gonna ask, what would you do in two very similar scenarios? And I'm gonna purposely leave out a lot of data and a lot of info because it's more fun this way. This is a 64-year-old, we're gonna say, with newly diagnosed glaucoma, not on medical therapy, has a pressure around 22 millimeters of mercury in both eyes. These are the 10-2 visual fields. So you see the right eye and the left eye. So this patient walks into your office tomorrow. What are you going to do? You're going to start with laser. You're going to go to medicines. You're going to think about intracameral drug delivery, maybe some microinvasive glaucoma surgery, traditional surgery. So I'm going to give everybody a few minutes to think about this, and maybe just quick. Anu, what are your thoughts when you initially see these visual fields as everybody's answering the poll?
Well, I mean, looking at the fields themselves, obviously these are 10-2s, which tells you that, they're severe disease. So obviously your radar is a little bit peaked in this case. And you may want to think about what your target pressure is. And that's usually what I sort of talk to my students about. The first thing I think about is, where should this patient be? Pretty young, 64 years old. But the pressures, they're 22, 10-2s are pretty severe in that left eye. Something to keep in mind.
Jess, how about for you? When you have severe disease, is it always a certain target? Do you still try to individualize it? How does your brain start thinking through this?
I really start to think about this to say, what does their future progression look like? And it starts by understanding what their past progression has looked like. So we see a 10-2 field with a pressure of 22, a good indicator that this patient has, without aggressive therapy, an unfortunate functional long-term outlook. So we're talking aggressive in this standpoint, especially considering the age as well, but it is always targeted to that patient. What other risk factors exist? What is the family history? What is the central corneal thickness? What other risk factors are here?
All right, great questions. Purposely left all that out because I think it's going to be kind of fun. And so we can see what the results were. And I'm going to quickly just move on to the next question because I have a goal in mind here. I'm going to try to get to it and see if I can make it all make sense. So same scenario, 64-year-old, newly diagnosed, no medical therapy. These are your 10-2s. They look a little different. I'm going to re-push out the poll and want to see what people would do. Anu, Jess, different thoughts. You still feeling just kind of the same way? Got a 10-2. Again, I know not giving you enough information, but just kind of initial thoughts of this 10-2.
Again, pretty similar. I think that anytime the central 10 degrees is affected, you just have to start thinking about potentially being a little more aggressive.
I don't see, based on the information that we have, a significant difference between this case and the previous fields that we saw.
And I think, Joe, you kind of talked about this, in our discussion section earlier about, sometimes if you're zoomed in too much, we don't know what's happening, on a 24. And I think that information, I think it's also important as well.
No, it totally is. And the reason I bring this up sometimes, especially for some of the younger docs out there, you really got to do your homework. You got to obtain all the pieces of information yourself. One piece of data often does not tell the whole story. A lot of times, a student come out of their own back, yeah, they have loss on the 10-2, it's severe disease. This is what I think we should do. And I'm like, oh, wait, like you said, Anu, what's the bigger picture? What does the disc look like? I mean, I get it. I get sometimes we get so focused on a certain type of objective testing, but there is the broader picture here. And there's, as Jess pointed out before, there's the functionality of the patient, which I think I'm getting better at as I do this more years, about asking the patient how they're doing with things and how they're just feeling in general about their vision. And so looking at the poll here, again, a little bit of a different mix, even though it was a very similar case, but we do see a good number of people going with laser trabeculoplasty in both cases. Medical therapy, not surprising, about a quarter to a third. And there are some who have recommended some more aggressive surgical interventions. So I'm going to turn this over to you both. And so medicine, laser, tell me why. Tell me why we're big fans of laser. What are your thoughts on laser at this point?
Yeah, so in terms of laser, I think that one of the big things to consider is that, I would say laser is always on the table. With the light study, it seems that it is a very effective, treatment. And in terms of the side effect profile, it is actually quite low. There's also benefits in terms of potentially better IOP control in the nighttime. So in the case of a, patient on a medication like timolol, where you might not get that lower IOP at night, the laser is beneficial for that. I do want to mention this. I mean, in terms of the light study that has recently come out, were there patients who were severe glaucoma in the light study? There was a small cohort. I think only about 6 or 7% of the cohort was
single digit, very small. And I think that's important because people, again, I see this like every time I feel like I talk. Taking the results of landmark studies and trying to generalize it and make it applicable to the patient in front of you, it's not always that simple. I mean, you can't just say, oh, first-line therapy, laser for everybody. It's a little bit of a different situation here. This patient is not really the type of patient who was included in that study. I think you bring that up, and that's important because I think we forget to read the methodology sometimes and see who was included. We just sort of, gravitate towards, what's the take-home point from this study?
Yeah, that's exactly it. So although, in that particular study, after 3 years, approximately 40% of patients actually were able to achieve drop-free targets. So I think it's on the table, something to definitely consider. Jess,
meds first. Give me your argument for that.
In my practice, meds first makes the most sense. As far as access to SLT, sometimes it is an additional 2 or 3 steps based on the patient's insurance or possibly lack of insurance to get them to where they need to be. Typically, medications first. When we talk about advanced disease and medications as a first-line therapy, I do still think there's an important role. Thinking about SIGITs and medications versus incisional surgery. The medications in the mid-1990s are not the same topical intraocular pressure lowering medications that we have today. Prostaglandin analogs, Rho kinase inhibitors, medications that increase aqueous outflow, increasing and acting on natural physiology rather than disrupting natural physiology by reducing aqueous production, I think do play a big role, even in the management of patients with advanced disease.
Yeah, I concur. This will be a debate that we carry forward, and it really comes down to so many other factors that I didn't sort of purposely leave out here, but medicine, laser, surgery, they all have roles. I agree, Anu, laser I love. I actually like it a little better second line, but there's nothing wrong with it first line. I tell people the biggest downside to laser is it doesn't work in everybody. Jess, I agree. We have so many great medicines. They really are reliable. No matter what anybody tells me about compliance, listen, for decades, medications have worked. They've kept so many people from losing vision. So, you're going to be hard pressed to take that out of my, out of my armamentarium. The one thing I will say is, we talked a little about earlier surgical intervention, whether it's MIG surgery or even traditional surgery. I think we can't forget about doing traditional surgery a little bit sooner for certain patients because there is the issues with compliance. There is the issues of toxicity of medications. And if you look at these patients, so this is patient 1 here, and we said what we could do laser, medicine. It was kind of mixed. But if I showed you the rest of the picture, I got to tell you, in their early 60s, I'd be thinking about doing trabeculectomies on both of these patients' eyes, because this is a pretty significant amount of field loss with a significant amount of disc damage. So I think one could make the argument here to jump to surgery earlier. Again, it doesn't have to be right away, but there is new literature coming out from the UK. There's been, evidence from the CACG study about, how important it is to be more aggressive early on. And then this is the second case here. We see, some 10-2 defects, but then you sort of zoom back out as a new set and you look and you're kind of like, this is a great case that just presented. And it's kind of like, okay, here's a little more of the story. Now you could say, well, has there been some stability? There is some progression on the visual fields, how aggressive to be. It's hard. So that's a lot to cover in 10 minutes, but I think hopefully we just illustrated a few simple points here that, it's really all about looking at the whole picture. There's tons of tools that we have. And that's one of the great things about being a specialist at this point for any of us, optometrists, ophthalmologists, glaucoma specialists, comprehensive doc. We have a lot of tools. We just have to learn how to use the proper tool for each patient. So thank you guys so much. I think this has been a lot of fun, and I don't want to run over. So I think we'll end it here, but thanks everybody for listening.
Thank you.
Thank you.